from United Kingdom, Dr. Abdul Hafeez. So Dr. Abdul Hafeez, please introduce yourself in some details and then go ahead with your presentation.
Thank you very much. It's nice to be part of this excellent initiative by IPNA. And obviously, I represent Association of Pakistani Physicians and Surgeons in the UK. Perhaps UK is obviously quite similar body, which is 12,000 doctors which are based in the United Kingdom. It's a pretty big number. Background is family medicine. I've attended a few of the previous webinars, and majority of
Dr.
discussion
Hafeez,
has been hospital-based.
sorry to interrupt you. आपकी आवाज थोड़ी सी break कर रही है. I'm not sure कि attendees के लिए भी अगर कर रही होगी. Maybe you can, at least for the introduction, you can turn off your video, and maybe that will make the audio less interrupted. And please repeat the introduction.
Just a second.
Ji, please go ahead.
My name is Dr. Abdul Hafeez. I'm a family physician based in Manchester. I'm a family physician in Manchester. I've attended a number of previous and majority of time the discussion has been hospital-based as well as intensive care. Obviously, there has been accident sessions as well. So in discussion with Dr. Danish, we thought it will be a good idea to actually start a discussion in terms of what happens in primary care. And I think that's what I'm going to briefly discuss first, and then we'll move on to the in terms of understanding primary care work, I think it is important to give a background in terms of how primary care works. The areas which I'm going to touch a bit more relevant as if someone study the system as the secondary care arm and primary care arm, and the whole healthcare is state funded. Obviously, the taxation on the big, but it's a point of view. So you can access any in for example, and they are secondary care. In primary care, they will, on an average, will be about 50 to 60 what we call GP surgeries, or what you can say clinics. And these clinics are all independently commissioned. So we are not employees of the state or any other organization. We work as an independent. However, we follow monitoring in terms of how they fund, and in terms of planning of things most cost effective, because by keeping an eye in terms of data of each of the doctor which is working in the primary care center, it actually improves the efficiency of the system. 90% of patients within UK are dealt with in the primary care setting on a daily basis. And obviously we look after patients from, in the beginning when symptoms of any disease are mild, and then we look after those patients which are discharged from hospital. And obviously they might have some clinical needs, but may not necessarily need a hospital bed for that purpose. So we work on both sides of the patients who become acutely unwell. So with that background, I think I'll just move on to my today's topic. Obviously, as has been discussed many times in our previous presentations, the COVID-19 is a big issue worldwide. And obviously, UK is actually becoming a hotspot at the moment after China and then Italy and then Spain. And obviously, I'm not going to go into much detail of the numbers. Very briefly, I will touch on the classical disease presentation. Most of us, I think, are quite aware. The incubation period is, it's variable from 6 days to 2 weeks. And that's the time when patient can actually be shedding virus even before patient has any symptoms. So this is an important point because normally we think, or general public has this perception that if someone has actually cough or actually vomiting or actually have any symptoms of flu, we need to be careful. But essentially, the patient might have no symptoms, but we still need to be actually be aware that this person might still have COVID. The start of the symptoms usually from day 5 onwards. Patient during the first week has very mild symptoms. Is actually the second week, which actually the crucial part. 80% of patients in the second week, they will make good recovery, and then obviously nothing will happen. The 15% patients, they will move on to having, start of shortness of breath, and about 15% of these patients might need some sort of help, might need to be going to hospital, maybe a brief visit, might need just oxygen. However, about 5% of these patients become more unwell, and obviously these are the patients who we believe end up in intensive care units. And obviously there is a background number of theories in terms of cytokine storm and multi-organ failure and rapid progression. And obviously I'm not going to go into too much detail on that side. Obviously then we move on to some atypical symptoms, which actually sometimes can catch us out. Sometimes patient can present just with diarrhea or upset stomach or abdominal pain. Some patients have reported loss of sense of smell, anosmia. And there's another interesting finding which we have seen in many patients, that some of these patients actually have hypoxia. So they may not necessarily be looking unwell. Normally, if oxygen levels go down, patients become drowsy and sleepy and so on. However, many of these patients actually, which we have observed, that they may be just chatting, normally looking normal, maybe a little, short of breath, not excessive shortness of breath, but when we put SAT probe on them, the oxygen levels are really low. And this is an important indicator from family physician point of view to have that facility in place that we check oxygen level, because that will determine if patient need hospital admission or not. And obviously these patients, the ones which are gradually deteriorating, they will be calling the doctor. You can have the facility where patient can speak to a doctor on the phone. So we will get number of phone calls from these patients, and then every day they will say, my symptoms are getting worse, new symptoms are appearing, and so on. So we really need to worry about our patients who are alone, might have dementia, have lung disability. There's nobody to attend to them when that just happen quite fast, and so on. So when obviously when the patient comes to us for the first time, in the UK for last 4 weeks, nearly 3-4 weeks now, we stopped all face-to-face contacts everywhere. It includes family care as well as second care. unless patient is actually unwell, which means patient needs to be seen and the issue cannot be dealt with on the phone. So usually in a typical clinic, we will have a list of patients who want to speak to doctor because of the symptoms. And obviously when we receive information from them, we have access to their full medical records. And then obviously we look at the risk factors. And those risk factors are, as probably you're aware, the old age, patients who have hypertension, who are diabetic, patients who have high BMI. And quite interesting finding now is that within UK, and I think similar data is coming from USA as well, the patients who have who are BME community, Black and minority ethnic Asian patients, they are at a much higher risk in terms of having disease as well as dying from this particular condition. Within UK, the latest information which we have now is that 32 staff members, medical staff, have actually lost their lives. 14 of these were actually doctors, and 18 were allied health professionals like nurses and healthcare assistants and pharmacists. But a very big number, I think 10, 12 doctors out of 14 are BME, as well as 10 out of 18 are BME in terms of paramedical staff as well. And when we look at the general data, apart from just the medical staff, 35% of the patients who are in intensive care units or intubation, they are actually BME. However, BME in terms of population, it might just be counting for about 15 or less than 15%. So it's a much higher. And similarly, male patients, the data also shows, intensive care data, that there are about 70% patients who are male, as well as the more worrying fact, which didn't come from China, is a young population is being affected. 25% of patients in intensive care units in UK are under 40. I think the youngest has been about 16 years old and so on. So with that information, obviously we stratify in terms of the risk. And if the patient is in the high risk category, we make a telephone consultation. And so these are the patients who are actually presenting with cough and cold type symptoms. So the advice within UK, or the procedure which we are following here, is we just, based on the history, we are quite lenient in terms of issuing them some medication like antibiotics and simple paracetamol, and advising them to take a lot of fluids. The antibiotic which we choose here, unless patient is allergic to it, first line which we use is doxycycline. We use 200 milligram on day 1 and then 100 milligram every day. And then obviously if there is any allergy or anything, second line we use is amoxicillin, 500 milligram 3 times a day. This is quite a typical pattern which we have been using, and obviously with appropriate advice in terms of if symptoms are getting worse, then patient has to obviously contact us and so on. And so this is typical what happens during the first 1 week of the illness. And during the second week, obviously, when we suspect things are going to get worse in terms of oxygen levels, hypoxia, and difficulty in breathing. So that's the stage when we probably have to check patients' oxygen levels. And these are the patients who might need to be brought in. And the way the system is designed, or has actually modified itself in UK now, is we have created what we call COVID hubs, or hot clinics. And there are hot clinics within the primary care center, and actually similar hot clinics and hot zones or red zones within the hospitals as well. So if we feel this patient might have these symptoms, and obviously I did talk about atypical symptoms in the beginning. So these are the patients which are actually referred to that particular area, where doctor will see these patients in appropriate protective gear. And obviously we need to probably understand a little bit more detail in terms of what that PPE mean. I'm not really sure if people in Pakistan have access to all those protective gear. However, the recommendation within UK is that you need to have, if you're working in the hot zone, an FFP3 mask, and this is bare minimum. Along with this, obviously, a surgical gown. Um, in addition, you need eye protection, visor, or maybe some sort of goggles and so on, covering your head. Long. Usually, we recommend double gloves, a long glove, long, longer, and then obviously a short ordinary glove on top of that as well. So this is for the people who are working with confirmed cases. However, generally in all the other clinics which we are running, we are using N95 or KN95 masks. So that's the bare minimum in terms of stratification, and then your protection, and so on. Within the hospital settings, what we are seeing is, because the pressure in the hospital, obviously all these patients who are becoming acutely unwell and short of breath, the hospital have modified about 1/3 of their beds into COVID, COVID wards. And even within accident emergency, we are obviously stratifying these patients as well. And there are hot zones within accident emergency, which are bypassing the other people who may be attending, and so on. So when patient obviously is suspected, the testing within UK has been quite different as opposed to other countries in the world. Initially, we were testing all patients in the first containment phase. However, then we moved on to only test if patient need hospital admission. So actually, the figures which are publicly available within the WHO website and so on, they are not true representation in terms of the total number of patients who have the disease, and that's why the mortality data from UK might be a bit skewed. I mean, the numbers are currently showing about 10%, 5 to 10%. Obviously, different centers are reporting different numbers. However, obviously, we will probably know a bit later on when the testing actually is more widespread and so on. A negative test result doesn't mean anything, because what we are seeing is, if patient clinically has all the symptoms and a typical history and a story, then we generally do not just rely on a negative test result. If X-ray shows bilateral pneumonia picture, patient has low SATs, as well as some other features as well, then we just repeat the test and continue treating these patients as possible COVID patients. Obviously, because of this current pandemic, the demand on our rest of the clinics has actually reduced a lot. We are seeing much less activity. All routine procedures have been actually cancelled, which is helpful in terms of redeploying all that staff and training them in terms of running the ICU and how to use ventilators and so on. So this has been a huge change in terms of how we are modifying the system. And I mean, within hospital, we have now a military style command and control place where all data is being obviously looked at. The availability of the ventilators within that hospital or nearby hospital is centrally monitored, so patients can be moved from one place to another place, or one clinic or one city to another clinic, obviously depending on the need and so on. We are also facing a big issue in terms of our staff going in isolation or sometimes becoming unwell. The guideline from Public Health England is, if anyone in your family develop cough and cold symptoms, the whole family should go in isolation. And they have, obviously there's a hefty fine in terms of if you are breaching that isolation rule. And there are many doctors who have actually family members who are obviously becoming unwell and so on. That actually affects the number of staff which is available to run the hospital as well. And that's why there is a talk in terms of doing early testing on these doctors who might be in isolation because of some other family member being ill, but they are feeling well in themselves, and so on. But obviously, this is something which is in the pipeline. It's not happening at this very moment. But obviously, in terms of planning for further, cases and deterioration in the overall system, this is something which is important in terms of, the rota should be run in a way that there is a flexibility, and keeping in mind that there will be about 20% of the staff which can actually go sick at any stage. We have actually stopped all the visitors coming in any hospital as well as clinics. And if there is a patient which is a child, then we allow only one adult to accompany them. The testing, the swabs, we have actually created pods outside accident emergency. So patient, even before entering that actual building, actually go through that system where the screening takes place. And I think there are a lot of, obviously, another very big issue is in terms of, staff health and how doctors feel, working in an environment where their own life is at risk. And you have seen, pictures in terms of, doctors' families being stressed out, because all the doctors themselves, are at risk, and their families understand that their own family member might bring virus in the house. We had discussion with some colleagues, very young doctors, and when they see their own, their own, colleagues in their own hospital going on ventilators, there is a talk in terms of writing a will. There is a talk in terms of pension, and obviously this is actually quite a frightening, experience in terms of working in those situations. But there we go. This is one of those things which we have to face in our life, and we obviously, see this as one of those things which we have to just do our job despite taking all those risks. However, it is advisable that we should not contact the patient with any patient, not just necessarily a patient who has cough or cold, to speak to them on the phone first, assess whether the patient is a high risk. If it is high risk, then obviously we must wear protective clothing, proper protective mask, and so on. I think I'll stop here for any questions now. Thank you.
Thank you so much, Dr. Hafiz, for this wonderful review. So I want to again stress and share with the attendees that it's our pleasure to have Dr. Abdul Hafeez, who's a family practitioner and works with APS UK or APSUP here. And I think because of that, I am trying to focus the theme of the discussion today to the COVID-19 infection in regards to family practice and primary care practitioners. So I tried to gather a mix of panelists who I think will be great in terms of making comments related to primary care issues and challenges, including from Pakistan. And would try to focus that a little bit more than subspecialty today. I also want to remind attendees, please write your questions in the Q&A box if you have anything related to it. And then I also encourage attendees that if you want to make any comments and want the microphone, then please raise your hand and I will try to come to you and give you the microphone and so that you can make your comment and even ask your questions live with a microphone. So make sure you have a microphone connected with your Zoom and just raise your hand. So before I start with the Q&A, I want our panelists to just briefly introduce themselves one by one, and I will go alphabetically like I have them in my list here, and I will call your name. So please unmute yourself when I call your name and introduce yourself, and then we'll start with the Q&A. Dr. Asima Chima. Dr. Shakil Mirza, please unmute yourself and introduce yourself. Ji sir, please introduce yourself. Dr. Shakil, you're unmuted, but we cannot hear you.
जी डॉक्टर दानिश डॉक्टर शकील
Ji,
मेरे साथ
sir,
है।
please introduce yourself.
I'm a consultant physician from Pakistan, practicing in Rawalpindi.
Ji, thank you. Welcome. And Dr. Imjad Hussain, please introduce yourself.
Assalamu alaikum. I'm Dr. Imjad Hussain, and I'm from Pakistan. I'm calling from Jhang. I might be having some troubles today. I'm not really sure if you can hear me.
We can hear you fine right now. And then Dr. Farhan Kadir, please unmute yourself and introduce yourself.
Assalamu alaikum. I'm from Rawalpindi Medical College. I'm living in Cincinnati. I'm a nephrologist and a critical care at UCMC, University of Cincinnati Medical Center. Thank you.
And Dr. Fizia Harikar, please introduce yourself.
Assalamualaikum. I'm Dr. Fizia Harikar from Indus Hospital, Karachi. I'm an infectious disease specialist.
Thank you. And Dr. Kaleem Ahmed, please introduce yourself.
Assalamu alaikum. Lee Ahmed, pulmonary critical care and sleep medicine in Maryland States.
Thank you, Kaleem Bhai. So Kaleem Bhai will be our expert for any intensive or ICU related questions. But hopefully we'll do a little more focus on primary care today. And I want to start with a couple of questions before I go to attendees as they raise your hand. Again, please raise your hand if you have any questions or comments. Let me start with a few questions posted today before I go to the questions from our WhatsApp group. And Dr. Hafeez, please, you get your first shot to answer these questions before I go on to any panelists. So the question is about, as a family practitioner, how are you thinking about testing yourself? Should family practitioners be tested, or physicians should be tested because they are providing first line defense? And then, over the last few days, there have been questions about how to provide primary care in the setting of this online COVID infections. A lot of physicians in Pakistan are continuing to keep their practice and they continue to see their patients. So I think these two questions are kind of related. Please, what's your take on it?
The advice at the moment is not to test everybody unless there are symptoms. So obviously, because we are generally reducing the contact with the patient anyway, for example, in my clinic on Friday, in the whole day, normally I see about 30, 35 patients. But there was only one patient who I need to see face to face. All the rest were on the phone. Obviously, this is a temporary measure. We have introduced a video consultation where we can actually see the patient on the video, or sometimes we ask the patient to send in a picture of their rash or any swollen leg or anything, which gives us a better idea in terms of whether they need any further tests or antibiotics and so on. So that in terms of testing, it is not recommended for everybody. However, obviously, if someone develops symptoms, then we must go in isolation and avoid contact with the patient. The issue which we have at the moment in Pakistan is obviously because the way system is run, because we are from Pakistan, we understand how clinics are operating. They probably do not have that facility which we have in other countries, where all patients are registered with us and we have their contact details and so on. However, in terms of when we think, to protect you and your family from such a nasty kind of virus, which is actually a killer and taking many lives, and we are seeing obviously so many medical health professionals being affected badly, I think we need to think in terms of what can be done. Rather than seeing a big number, obviously we should reduce the number of patients coming in the building at any time. And obviously, when they come within, for example, in the waiting area, there should be, the seats should be well apart, I mean, wide apart. Maybe, I mean, in UK we recommend 2 meter distance between any two people, and that includes in the waiting room, as that includes in the reception, that includes even outside and so on. So it's better to have a queue of patients which is outside for their own protection. But obviously there has to be a big public, media campaign in terms of how things should be done, because otherwise patient might feel offended in terms of if we ask them to do that.
Thank you. Our colleagues from Pakistan have any comments, Dr. Imjad?
Yeah, I think the main thing is to be testing, because in Pakistan the main issue is still, I believe, is testing. We are not doing enough, not even enough. We're not doing the minimal kind of testing here, and I think the response here is a bit disorganized or chaotic, I would say. The disease has already been into the community, so I think we should kind of revise our suspicion and our criteria about the testing thing. So we should be doing far more testing. And I think one more thing, that if we see patients like they do not have young patient and other who do not have very much symptoms, I think we should not be allowing them to be admitted in hospitals.
Dr. Shakil, do you have any comments?
I agree that the testing over here is not up to the standard where we can detect maximum number of cases, and that needs to be ramped up. And I think the government is trying that, but unless the private sector comes in into the play for that purpose, the population dynamics of ours are such. For example, I had a patient yesterday, and home after seeing with due precautions, I suggested that he should be tested. He had been having symptoms for about 3-4 days now, and he had seen an ENT specialist as well. He did not want to be tested for the fear of the sheer logistics involved, that he had to go into a government sector hospital where he would have to wait a few more hours. And then he didn't know what would happen. There is a fear about being quarantined and isolated and sort of imprisoned and something like that. So there are issues with the testing in terms of capacity, and there are issues with the testing in terms of the process. And until those are eased off and more tests are more widely and more easily available, as said, as Dr. said, there are pods outside the A&E and or the GP practice in the UK, and where they can get very easily tested even before they come in. I think something of a similar nature, where more wide availability of testing is available, this is really need of the hour. Thank you.
Dr. Shakil, can I ask something?
Yeah, please.
Dr. Hafeez here. What happened with that patient? What happened with that patient who needed a test? Did he just went home, or what advice was given to that patient?
I got him tested from a private lab. There's a private lab called Chuktai Lab over here who do tests, and I get it tested from him, but that costs money, and that patient was affording enough. He has gone into isolation at his home, and we have got his number, and we've given the number to the team's people as well. And if his result comes back, the district administration here is very proactive. And I must say that, for example, where I live, there has been a case over here. He reported himself. He went to a private hospital nearby. He got tested, and all his family was then screened, and then they were isolated in their home. The whole street was quarantined, and ultimately his test came back negative, and then the streets were open. So I think the government is doing its bit, but it's just the enormity of the problem, one, and the complexity of the problem, two, in as regards healthcare professionals, that we need to devise more systems and open more areas where especially testing can be done.
Thank you.
Dr. Fizia?
Yeah, hey, just let me. Assalamu alaikum. So I have a couple of comments. For one, I think there's a little difference in how things are being run in Karachi. It all started with the private hospitals taking the major bulk of the patient testing and treating and admitting. So I think Ahan and Indus Hospital took the lead, and then we had OCHA, which is Dow University Health Services, took on, and now we have SIUT joining in for the major bulk of the patients getting tested and stuff. So testing as such is yes, definitely we may. That's like a limitless thing that we need to test. But the thing is that we also have to realize that we need to screen the people appropriately. So how things are being done here is that we have two types of teams. One is a hospital-based team, and then one is a community-based team. The hospital-based team screens and tests all those coming into the hospital, whereas the community-based teams then goes into the community and looks at the family clusters of the positive patients who have come into the hospital. So that is how they are trying to find out the positive cases. We also have and where anyone who wants to get screened and tested, so those who come positive on screening too, they get tested as a drive-through thing as well. Nice way. All these patients, all the patients who are coming and needing primary physicians in this are registered. So we are not taking in new patients in the family clinic, but we are for all our specialist clinic and family physician clinics, we are calling our registered patients who had their appointments for the last, for the future 2-3 months, and on their days they are called, and we do a telephonic call about how they're doing, how they're wearing, and take go ahead from there. But however, those patients who do need family physicians and they line up in the ER, and then so from there we've started our family physician clinics from 8 to 8, which is a 12-hour clinic in shift, which is being run with all the proper PPEs so that we do not miss out on diseases which are non-COVID related, with all the precautions in place. So I would say that the way we have a structure in Karachi, we should not advocate general physicians at this point in doing clinics for now, because the community transmission is scarily increasing in number, and the number of, because we've entered into the second and the third week, the number of severe cases are increasing, and the number of doctors that are being infected is also getting increased. We have another paid doctor who is on vent right now. So I would just say that till you do not have the support, please do not do your clinics. And I do understand that the type of population we have is very, very poor. Doing a telemedicine clinic will not probably be a very easy when you don't have a support of a tertiary care hospital behind you. Thank you.
Very good. Thank you, Dr. Fizia. So I want to make a comment that panelists, please, if you have a comment about ongoing question, raise your hand. That will make it easier for me to know that you want to add to the questions answered as Dr. Hafeez is answering or someone else's. And then let's try to get to a lot of questions today, and making short comments or answers will allow us to cover a lot more questions. We have a bunch of questions already available to us that we should try to touch on. So I'm going to go to a question that I don't think have been touched upon a lot before, which was asked by Dr. Mehrunisa, who has joined us kindly. She's the head of department for the gynae in Fatma Jinnah Medical University, and is asking a very pertinent question about risk to mother who is pregnant and is carrying a baby. Is it more during COVID infection? And is there any concern for risk to fetus or a newborn during the COVID-19 infection? Dr. Hafeez?
I think the risk, obviously, during pregnancy, as we know, generally the immunity levels go down, and any condition which is actually affecting the immunity or the immune response of the patient will inevitably affect more. And obviously, we are seeing more patients who are in that age group which are being affected. There has been cases reported of newborn patient or newborn child actually testing positive for corona. So obviously, yes, it is not only for the patient, but I think we have also seen the doctors, the consultants who are actually operating in that area, they are at a much higher risk as well, as opposed to some other wards.
Very good. Panelists want to add anything to it?
Assalamu alaikum. I would just like to add on that there is guidelines by ACOG regarding the pregnant woman. In terms of the data, there is only one case where there's a vertical transmission where the IgG and IgM were both positive. But most of the cases which the baby's been delivered, there was no transmission of IgM because of the size of the antibody. Yes, there was IgG and the immunity was transferred to the baby based on the further testing. So essentially, most of the time, the babies are protected. There is no data which support that the pregnant women do get more chances of having infection. But based on the guidelines, they still have the same kind of protection. There was some question about the preterm delivery. There are some cases which has been reported as a preterm delivery, but they're not really sure whether this is because of the COVID-19 or it's actually because that these patients were supposed to get the preterm because of the other risk factors. Hope that answered the question.
Thank you, Farhan. That does help a lot. And that also covered that question about any issues with the delivery itself in terms of family practitioners dealing with pregnant women who might be infected and near their term for delivering. Any comments there, Dr. Hafeez? Are the deliveries or process of deliveries or procedure different for infected mothers?
I think the all procedures, obviously, if they are being tested in UK. Any mother who is going through delivery, they plan, and obviously when test is done, and if test is positive, then obviously the whole system kicks in terms of full PPE. And
so another question related to primary care, Dr. Hafeez, is about depression and psychiatric issues. Are you seeing any increase in that, anxieties, depression, or anything like that?
Definitely there is a huge increase, and especially because of the lockdown now, we are seeing a lot more patients who obviously come with depression, but also just the anxiety of what will happen to them, what will happen to their family members, and so on. And in addition, other conditions like domestic violence, and obviously all those cases are much more. And obviously there's not much which we can actually do apart from just treat them as they are, and then just symptomatic relief, and try to reassure and advise them in terms of what precautions they should be taking and so on. But obviously some patients who have pre-existing anxiety and depression, they are really paranoid and obviously not leaving the house, and obviously there's a huge demand in terms of the mental health services here.
Very good. So I'm going to add another question to Dr. Hafeez, and then see if panelists want to add anything to the discussion. Dr. Hafeez, the question is about the face mask and sanitizers and personal protective equipment. And the question is that, is your clinic and hospitals providing those? Are they given as a prescription to prevent abuse? And how is that being managed in UK?
I think this is an area where UK has actually have been caught out. And the information which came from China when we were preparing for this pandemic was the disease doesn't spread by aerosol, and is actually just the droplets which, by contact with the surfaces which cause it. However, now the new information which is coming from UK and obviously from other centers as well, that the virus can actually be in air for some time, especially in closed spaces, especially if patient is on oxygen or is on nebulizer, and or if there is a positive pressure within operation theaters and so on. And that's why there is a trend. The doctors who have lost lives within the UK, many of them are surgeons, which we believe is related to the way things are actually operating. In terms of providing the equipment within hospitals, I think this is my personal view. The PPE which is provided in UK is probably I think is not enough, though we are now catching up after having more data and more information. They are actually providing better gear. The bare minimum mask, I mean, I'm not really sure if this is available in Pakistan at the moment or not, is FFP3 mask for confirmed cases or highly suspicious cases. The way things work, the NHS has provided even the family physicians with the equipment, but not FFP3 mask. We are just provided with an ordinary surgical mask. And that's why a lot of family physicians are actually trying to buy their own protective equipment here. However, there is a severe shortage. As an organization, Association of Pakistani Physicians in UK, we have actually done, our own, found one of the suppliers from China. We ordered equipment about 3 weeks ago, but because of the freight and the, everything is paralyzed, we haven't received anything as yet.
Does the panelist have anything to add?
This is Khalid Ahmed. I need to ask our panelist and speaker any data about the healthcare workers who are getting COVID positive. They are using the FFP3 or N95 with the shield as recommended by CDC and World Health Organization while taking care of the patient, or those healthcare worker, or those who are not using this thing or using surgical mask or getting in contact with some other normal interaction with the patient population.
Dr. Hafeez here, the information which we have is obviously these consultants who actually have tested positive and are very unwell, they were using the equipment which was provided. However, obviously we, in the beginning, things were not as strict. Obviously, people were a bit more lenient, and sometimes you rush to the patient without looking after yourself. Things are better now than what they were. However, there is a huge, uproar in terms of why the first 10 deaths in UK in the medical community were all BME doctors. So are BME at a higher risk than the native population, because all of them are using same equipment? And so obviously there are different theories on this. Obviously, as you know, because of the fast-paced movement of this pandemic, it will take some time before we can get to the bottom of this. The different theories, one of them is suggesting that with low vitamin D, especially people living in the European countries, and especially the Asian with thick skin and darker color, and obviously the sunlight doesn't absorb as much, and it's a very common case. Somebody else has suggested, because BME community has much more prevalence of hypertension and diabetes and all other comorbid conditions, probably that's the reason why a lot of them are actually getting severe disease. Somebody else has suggested is the thalassemia trait, which might be the underlying factor, but obviously these are all different assumptions. We don't really know what is the cause. However, data is coming is quite obviously it's not proving anything, but obviously it's quite important that there is something going on.
Dr. Imjad, you have a comment?
Yeah, I just wanted to say something about the mask thing. Actually, the mask is mostly it was not provided in government hospital early on, and now that they are providing masks, they have started giving masks to most of the departments and other areas. So, but still, most of the hospital they do not have a respiratory triage. I would say they should be having setups to triage patient before they could say they are suspected or not. So most of the young people, they are already exposed in emergencies and other areas, and and mostly the masks available here are of low quality. We do not really know if they have proper GSM or not, and people are not even trained about the use of masks. There is a lot of myths about using mask here in Pakistan. A lot of people say that you need to put mask in one way or the other. For example, if you have disease and you do not want to give it to other people, you wear it in other way. And if you are trying to avoid from contracting illness from your patient, then you wear it in other way. And I
Let me
think
take
they should.
another physician in the discussion so that we can continue this. So, Dr. Mohammad Azim Imran, please go ahead and make your comment or question with the panelist.
Assalamu alaikum to everybody. My question is only pertinent to the GP clinics which are running in the private capacity, because we are belong to the major chunk of the people which we are dealing, and we are the first liner which are dealing. As the government hospital OPDs are closed and only the emergency work is only done, and the GPs, the load to the GP is increasing. So, in my opinion, the minimum recommendation for the GP clinic should be in the waiting area. All the PPEs should be provided to the staff which are dealing with the registration counter along with the vital counters, and in the clinic of the doctor, the chamber of the doctor should wear the all protective measures, because uh, moreover, at the entry point there should be a sanitizer, and there should be an isolation for the patient with the upper respiratory symptoms, and moreover, the hospital waste should be properly disposed of. So these are my opinions. I will be happy to know if there is more to do. Thank you very much.
Thank you, Dr. Azim. And I want to add another message sent to us in a webinar from Interior Sindh, in a small town in Sindh. Dr. Om Punchi was asking that, I'm still coming across with, I have to see about 100 patients in my clinic every day, and I have no idea who might be COVID positive or negative. What kind of preventive measures can I take to protect myself or others? Or is it enough to wear a surgical mask or frequent use of sanitizers? So let me start with Dr. Hafeez and then add panelists later on. Dr.
Yeah, I
Hafeez.
think as I suggested earlier in my presentation as well, obviously I will not, recommend bringing too many patients inside a small closed space, all together. Make sure the windows are open so there is cross ventilation going on. And then when you are examining patient or taking history, obviously, I would suggest, obviously, the simple surgical mask is not good enough. What we recommend as an alternate, but not ideal, is KN95 mask, which is a relatively cheaper version, which is coming from China. It's a Chinese code, KN95, or N95 masks. Within UK, we are actually using double mask. So if we have KN95 mask, because it's actually closed from side as opposed to a surgical mask, which is only to prevent splashes rather than air. And then obviously we try to wear a surgical mask on top in terms of providing a little bit more extra filter and so on. And then we recommend that you do not go very close to the patient. Obviously stay at least 2 meters apart. And then within UK, it is advisable that you do not look at the throat, as we typically do during throat examination, because that's a high risk, very high risk procedure, and then shed a lot of virus in air and so on, which is dangerous for everyone else. We just based on the symptoms, we try to treat these patients. I mean, in an ideal setting, a patient who has cough and cold symptoms should not be allowed in the clinic. And then obviously it's a better, if possible, to speak to them on the phone and then just give a prescription.
Thank you. Does the panelist have any comments?
This is Khalid Ahmed again. Regarding this data, I think it is very important to get the data about effectiveness of the current recommended PPE for the healthcare worker. Reason is that we know that there are so many healthcare workers being affected. And if we know that those people are wearing the guideline, like N95 over FFP3 mask with face shield and gloves, gowns, and everything else. And if still they are getting infected, then this is something which is, we need to look into that. Reason behind that, when the Society of Critical Care, when it published its recommendation of the management of critical air pollution with COVID, they were saying that using the surgical mask is as good as N95 if one is dealing with non-aerosolized procedures and environment. And they cited the study from the Journal of Evidence-Based Medicine from 2009, when there was a study done on influenza A about 1,000 healthcare worker in Toronto area, and they checked the inferiority of the surgical mask versus N95 mask, and the number of cases which turned positive in those two groups were identical, almost. So that is something which, if we can get the data from our institutions where there are a large number of people are engaged, a large number of patients coming, that might help us as a healthcare worker to adapt or ask for a better kind of PPE rather than just what we are using right now.
Dr. Farhan?
Ji, Assalamu alaikum again. I think it's very good to have a data from US, but unfortunately, people who worked in Pakistan, like I worked in Pakistan, the data is very hard to replicate in Pakistan, unfortunately. Even if you have the mask, remember that the mask is to protect others from you, but at the same time, if you see a COVID patient, that COVID patient, your mask get infected. And in Pakistan, when you have this going on, it's very important to realize that if you see one COVID patient, which is going to infect your mask, then mask can get in, then you can actually infect your other patients who are not COVID positive. So what I highly, what I told my family to, is to use a shield, which is, you probably have seen the plastic sheets which they've been using. It's easy to use hydrogen peroxide or any kind of alcohol-based sanitizer, seeing every patient, and it does not infect your, it gives you an extra shield on your eyes and all that too. Having a mask without an eye shield is as useless as anything else based on the data. So
Dr. Khani?
I was actually going to talk about the shield as well that Dr. Farhan just mentioned. And in addition to that, the shield, not only does it not only is it easily cleanable, but also it prevents you from touching your face, which all of us tend to do before you've had a chance to wash your hands. And then also strict hand washing between patients. When physicians go home, they need to make sure that they're not bringing their stethoscopes or any kind of fomites with them from the office. That doesn't need to come home. And then obviously taking a shower, including washing your hair, etc. All of that has been recommended before you come into contact with the rest of your family.
Thank you. A couple of simple, straightforward questions from Dr. Hafeez, specifically before we go on to another difficult topic. Dr. Hafeez, a question about, have you seen any increase in blood pressures from anxiety and need for increasing blood pressure medications? And have you seen any increase of over-the-counter medications like zinc or magnesium or vitamins?
In terms of blood pressure medication, obviously we haven't actually seen a huge number of patients because the face-to-face contact is actually quite low in our clinics. And I think in terms of if the high blood pressure is because of something else like anxiety and so on, then we should be treating the primary cause rather than just focusing on the blood pressure. However, I will briefly mention in terms of, there is some anecdotal data in terms of use of ACE and ARB. So we are not obviously sure in terms of whether to use it or not because there's no conclusive guideline generated as yet. However, research is going on those lines. Over-the-counter medication obviously doesn't come under us. People can just go to a shop and buy it. So we will not have that kind of data available to us.
Thank you. So let me ask this next topic. I'm putting together 3-4 questions into a series, and Dr. Hafiz, for you, and then panelists can add. So the question is about how long is the COVID-19 patient shedding virus or infective once the infection starts in the patient, and then when should you do the first testing or PCR? What suspicion? And then if the first PCR is negative, is that enough, or what's the point about repeating the PCR testing? And then lastly, how often should you test for PCR to say, okay, now the patient has healed and declare the patient recovered?
In terms of the the disease pattern, usually illness lasts about 3 weeks. So obviously we do not normally start the PCR, and even the sensitivity of PCR is not 100%. There are different, obviously, brands and different makes, and there is a suggestion that there will be 30% cases which will be false negative. And so these are the patients. If they have other symptoms going on, we should just treat them as as a possible COVID patient and continue all those procedures. In terms of retesting, we only do if patient is positive and they are unwell, then we do retesting in terms of clearance, in terms of that the patient has actually cleared infection, and before discharge they are actually clear. In terms of shedding of virus, it is obviously suggested based on the crude information which we have, that the patient can actually be shedding virus for 5-6 days even before they become symptomatic.
G panelists, do you want to have anything to add?
Assalamu alaikum again. So in terms of shedding, it usually says that based on the data we have, the one paper actually showed 7 to 10 days. One paper shows at least 14 days. There's one paper which shows about that patients are also having the fecal shedding, which lasts for a month. But right now, based on the guidelines, it's usually 7 to 14 days, but they do not recommend retesting it at any place. I've never read it, and maybe other panelists can teach me on that. We do not retest the patient once they are positive. There are certain hospitals, and those are the hospital guidelines, that do have at least have 2 negative tests if you're admitted in the hospital to take the isolation off. And that's pretty much about it from my side. But in future, there is plan to do the blood testing to make sure what the antibody response is, which is completely variable based on the recent paper.
Thank you, Farhan. Anybody else wants to add anything?
I can tell what we are doing at Indus is like for de-isolation. If a person is admitted and he's asymptomatic, 5 days after being asymptomatic, we do tests, which are 2 consecutive tests. If they're negative, then we de-isolate them. That's what we're doing.
G. Imjad?
Yeah, in terms of testing, I think we're not really sure in Pakistan, are we seeing a different pattern in terms of testing and sensitivity of PCR? Because it seems we're having a lot of false negative in Pakistan, because they do become positive on probably second or third testing. So it could be an issue with a probe or something, or it could be just I don't know, it could be just another phenomena.
I think in earlier webinars, there was a discussion that there are many different suppliers of the PCR testing, and each supplier have their own sensitivity and specificity. And of course, the kits have to be maintained in a certain temperature and humidity and all those things. So the supply chain has to be maintained. All of that will affect the sensitivity and specificity of the testing. In best case scenario, best kit properly maintained, properly tested and used, it's still 70%, but of course it will go down if those things are not fulfilled. So another question that is coming up, and I think we have discussed it many times before, but I think it's worth repeating over and over again, is about use of hydroxychloroquine, prophylactic use of hydroxychloroquine, and a treatment use of hydroxychloroquine. What's the practice you have seen, Dr. Hafeez, in UK?
We are not using it. However, obviously there is a recent paper which is published in New England Journal only last week, and obviously that particular paper is actually talking about negative impact of hydroxychloroquine in terms of patients who end up having a severe illness.
Okay. Any comments on the panelists?
No, just to confirm what Dr. Hafeez said, the New England Journal paper was uh, showed an adverse effect with the use of hydroxychloroquine. The number of patients in it were only 63, though, so it was a small study. But from what we know right now, there's no good solid data that it's helpful.
Anybody else?
And also today, they just published the guidelines for Infectious Disease Society of America. And that guidelines also recommended that chloroquine and hydroxychloroquine should only be used in clinical trials and should not be used otherwise.
Imjad?
Yeah, I think there is a lot of talk about use of prophylactic use of hydroxychloroquine or chloroquine in Pakistan. And even I have seen doctors, they have been using it regardless of the reason, because if they see a patient that is positive or somebody is admitted in isolation, they just take it right away, regardless of whatever the recommendations are. And I was reading a few papers last night, and they were preprint actually. They were about to be printed, and they are showing promises in terms of treatment in at various stages of diseases in both in vitro and vivo studies. It's I just submitted one on YouTube actually last night, and but there is no recommendation for prophylactic use. And India is probably the one that is using, or they have kind of some H sort of recommendation or something, they said. And so,
Thank you,
well,
Imjad.
thank you
Dr.
very much.
Fizia? I think Dr. Fizia have left. So I think another question that is coming up is in terms of early signs of COVID-19 infection. For example, there is some talk about lymphopenia, leukocytosis, anosmia. Are there any clinical markers or lab markers that you can use to increase your suspicion about COVID-19 infection, Dr. Hafeez?
Generally, the white cell count is actually low, and sometimes it's normal. CRP has been, so I mean, very, very high levels have been associated with positive cases. Generally, is the history which actually is more suggestive. Patient who has classical, maybe a contact, maybe, symptoms, and then going into hypoxia and difficulty breathing. And then obviously with positive X-ray findings is more suggestive even when the tests are negative.
So an interesting question has been raised also about some animals in Lahore suffering from the coronavirus infection, as per the person asking the question. And the question is that, is it starting to spread to other animals? Is there any genetic shift that might be going on? Any thoughts or comments from speaker or panelists on it?
I think we had a similar discussion in terms of, there was, newspaper, again, anecdotal, reports that cats have it. Sometimes people are saying is the lions in the zoo had it. But obviously this is something which is quite anecdotal. We haven't actually confirmed, but yeah, it might very well be possible.
Okay. And then Imjad, please make your comment.
Yeah, actually, in terms of animal, I think it's not that important, because even if it's spread to animal, for example, it was seen in Nadia, the lion that was in Bronx Zoo, I believe. And the real important question is that if the animals are going to spread it back to the humans, like it's not the spillover, it's something different. The virus is able to jump from animals to human, and then humans to humans, but probably it's not being able to jump from animals back to humans.
Thank you. And as we are really running our time, let me try to close the discussion with one last question from panelists. Again, it's a question which is a mix of 3-4 different questions, and basically they're asking about procedures or processes for surgery. Are routine testing required before any going for surgery? Is there a different way of approaching minor surgeries versus major surgeries? How to keep operation theaters open? What should be a standard operating procedure for utilizing operation theaters for COVID-19 patients? So your thoughts on it, Dr. Hafeez, and then panelists?
Within UK, we have actually suspended all routine procedures. So only, the patient like acute situations, fractures, and maybe cancers and so on. Those are the ones which are going ahead. So the advice will be, because the data, the limited data, very limited data, which we have from UK, the surgeons are at a much higher risk in terms of catching the infection. I mean, obviously, there may be other reasons. It's being investigated at the moment. But while we investigate, it might be a good idea just to postpone, these procedures as much as possible. However, obviously, I'm not a surgeon, so the discussions which we had with our surgical colleagues, they are saying the positive pressure which is generated within the theaters obviously is actually produce more aerosol, and so obviously that actually increases the risk of anyone entering the theaters even later on after many hours. So obviously that's something which we might need to look into in terms of either make it a neutral pressure, or when we really have to do the surgery and then use all the protective gear.
Dr. Kabani.
There are, in the US, all elective surgeries have been disallowed. In fact, in the state of Texas, the governor put out a rule saying that nobody will be doing any elective surgeries. As far as semi-elective and urgent surgeries, of course, they are going on. The semi-elective meaning if somebody is borderline and they absolutely need it, or too much time going by can make them worse, then that is happening, except that it is happening in certain designated theaters, OR theaters, and the staff obviously is taking very strong precautions, the anesthesiologists particularly. They have intubation boxes that are separate, and they have this device where when they're intubating, they're not even taking all kinds of precautions in case. Now, we are not testing people that are going in for surgery preoperatively to see if they are asymptomatic carriers. China did do that. And there is data about that China had done that, and they're still not allowing anyone to go into surgery without being tested. Because what they found, both in China.
I think, Dr. Kabani, you're muted.
That was me, sorry, that's something in the computer. So what they found was that in Italy, during the epidemic, during their surge, 40% of the patients in the surgical wards that had come in for elective or semi-elective surgery turned COVID positive. That's a high number. So obviously there has to be a lot of care about that. The American Society of Surgeons has a lot of guidelines, if anybody wants to look that up.
Thank you. Farhan, you have a comment?
Yeah, so in my hospital, since we do a lot of Bronx and EBUS and all that stuff, so for us it's mandatory that we have to have a test done before a patient comes to the hospital because of the exposure risk, unfortunately. And even if they are negative, we're still taking them as COVID positive so that we can still have extra precaution, because remember, we are playing with airway for at least a couple of hours. So in my hospital, everything considered as COVID positive and protections are taken care of, but it has to be tested before semi-elective procedure for
Thank you.
biopsies.
Salim bhai?
Yeah, I think the same thing here in our institution as well. No routine surgeries are allowed, and we are following the same guideline.
Thank you. I see a hand raised by Dr. Harun Akhtar. Please unmute yourself and make your comment.
Assalamu alaikum. Can you hear me?
Ji.
Ji, assalamu alaikum. This is Harun Akhtar. I'm a family physician in state of Maryland, Frederick, Maryland, and our state has disallowed all the elective surgical procedures as well. But I want to comment on one very important aspect of this pandemic is on the emotional and mental well-being of the patients as well as healthcare workers. People are so terribly anxious. They are panic almost to the point, and they are thinking they are dying. They're gonna die. I said I have to tell them to look positive in their life, and the more they're gonna stress, the more they're gonna stress their immune system. So the best thing is to fight with this pandemic is to stay calm, stay positive, and look at the positivity in their life. same messages for the healthcare workers, and they are getting more panic attacks. So I think this is one thing we all need to support each other, especially we had talked a good discussion about how to prevent infections, how to prevent spread for healthcare workers. I think one thing I want to comment is that we have stopped having any patient in the waiting room. Patient has to wait in their cars. I mean, up until certain time, and now we are doing almost exclusively telehealth. And like in UK, we have 6 sites where the physician or the physician assistant see with full protective gear. But it's a transition in the initial stages when this starts spreading. I had told my staff to put every patient who's coming with upper respiratory or low respiratory symptom to have a surgical mask on them. Obviously, now we have to use N95 and then surgical mask on top of that.
Thank you so much. With that positive note from Dr. Haroon, I think we are way above time. We've 9:20 in Pakistan. Thank you so much for this wonderful session. I really enjoyed it. I think it covered the basis very well for all the primary care providers in Pakistan. It was pleasure having Dr. Abdul Hafeez as a speaker. You did a thoroughly wonderful job of explaining all the basic questions that the GPs have in Pakistan. And hopefully we can have you again in a couple of weeks to update us with any new updates. So let's call this a day, and we'll follow up with all our attendees today. And please let us know if you want to be speaker or panelist on these sessions. Thank you so much for joining us today. Thank you. Assalamu alaikum.
Thank you.